Thank you, Ms. and Mr. President, Dr. Presidents, chairs. I want to share, Rick, and welcome to everybody. This is amazing, 2,000 people. We could not have conceived of this a number of years ago, as Rick Geswell mentioned. But let's get on to the talks, because we always tend to delay things. So Bruce gave a phenomenal introduction to biologic therapy in IBD and focused on ulcerative colitis. And the good news is he introduced all of the agents that I'm going to talk about. But I'm going to take a somewhat different approach. Bruce talked about why our glass is half full in ulcerative colitis. And I'm going to take the topic a bit more directly of whether or not we should change how we position biologic therapy for their use in Crohn's disease. And despite all these great advances that Bruce spoke of, and I totally agree with those, I'm going to talk about why our glass is half full, half empty, and how we can perhaps fill it up a bit more. If I can figure out pointer only, that's pointer only. Okay. So, current positioning. Where are we at right now? In the 2009 ACG guidelines for moderate to severe Crohn's disease and focused on biologic therapy, and again, this is about 5 years old, but hasn't changed dramatically, recommending infliximab who have failed first, or the biologics, for patients who have failed first-line therapy with excellent evidence of that. In selected patients in whom steroids are contraindicated or not desired, where our level of evidence and experience is somewhat less. And natalizumab at that time, again, this is 2009, in patients who have lost response or to conventional agents and or anti-TNF agents at the time. Now, the AGA has updated guidelines. They took a different approach, and although I was engaged in this process, I didn't really like the way they analyzed the different drugs. They kind of took a negative approach to it, but their evidence was for the use of anti-TNFs to induce remission in patients with moderate to severe Crohn's disease, with strong recommendations for anti-TNFs over thiopurines, over thiopurine monotherapy, and more on that a little bit later, Jean-Fred, using anti-TNFs in combination with thiopurines to induce remission, and using anti-TNFs over no anti-TNFs to maintain steroid or anti-TNF induced remissions. You see, the language is not very user-friendly from our colleagues at the AGA. And then we also have relatively recent ECHO guidelines for moderately active disease. And to summarize these guidelines, the ECHO is also recommending biologic therapy for patients who have failed conventional agents or have become steroid dependent in a variety of different settings of Crohn's disease. Now, Bruce and I thank you for the acknowledgement of this slide. We are currently positioning therapies according to two different factors: the severity of disease at presentation and how patients respond to the initial introduction of therapies. And currently, we have been positioning biologic therapies, for the most part, in patients who can't get off steroids despite immunosuppressive agents, and then continuing to use them as maintenance agents. And then we've been inserting anti-integrins, currently vedolizumab. I think the use of natalizumab has probably declined, but we'll see what happens with that again in the future, perhaps. But biologics have basically been positioned for patients not responding to conventional agents or those who get stuck on steroids. Now, in contrast to ulcerative colitis, perhaps, there is a progression of structural damage in Crohn's disease that's been seen in repeated studies, and we've often gone back to this slide and think about where we might have impact on the disease course in Crohn's disease. Now, if we treat patients before they develop the structural damage, before they develop the strictures or fistula, we're going to have at least the potential to change that progression. But where have we been positioning biologic therapies to this point? We've been positioning them, and if you look in the clinical trials of infliximab, adalimumab, certolizumab in Crohn's disease, or most recently vedolizumab, we're looking at patients who have beyond 7 or 8 years of disease. These patients already present with structural damage. In the recent studies, 30% already have fistulizing disease when they're being administered these agents. The potential to reverse that is essentially nil at the present time, and they already have the complications that we would like to prevent. So let me assert that the problems with our current positioning are threefold. Number one, where we are positioning the agents, there's limited efficacy. And as I'll allude to, we can learn from the rheumatoid arthritis experience that administering highly effective agents, as Bill Sanborn might describe them, earlier in the course has the potential to modify the long-term disease behavior. The second comment, and as Bruce alluded to, there is toxicity of these agents that is primarily in the presence of concomitant medications, as we'll show you, steroids and immunosuppressants. When these agents are used alone, they are the safest and most effective agents that we've introduced. They're not as effective as steroids, perhaps, but they're much safer. And the other problem with our current positioning and how we can improve things in the future is the loss of response, and let me review those. So you know the different agents that we're using, infliximab, adalimumab, certolizumab, pegol in the setting of Crohn's disease. The problem that we have is that we've been inserting these into late populations. And I'm going to skim the data and just show you just represented aspects. This is remission at 6 months with the anti-TNF agents in Crohn's disease. And these are patients where we're currently positioning them who are failing salicylates, steroids, and immunosuppressives. And what is the 6-month remission rate? It's approximately 30%. We've got a long way to go for this. With or without immunosuppressives, we can improve things historically in patients with immunosuppressives by bumping it up maybe another 5%. But in these controlled trials in patients already failing immunosuppressives, the combination really wasn't a significant advantage. So where I think we should be inserting biologics is earlier in the course of the disease, and we do have some data. Now, most of you are familiar with the top-down therapy in Crohn's disease that was presented actually about 8 years ago initially, and then published 6 years ago by Geert Dans and the GETAD and the French Cooperative and Belgium Cooperative Group, where they took patients not at the end of the game, but earlier. These were patients who were steroid and immunosuppressive naive who had never received biologic therapy. And if we look at the proportion of patients in remission at the end of the year, here we see that we've increased the 1-year remission rates up to 60% by administering in an early population. And I will also tell you that this is a minimal estimate because, as you recall from this study, patients did not receive biologics in a maintenance manner. They received it episodically, which of course we no longer use. And so 60%, I think, would be considered a minimal effect from this strategy. And then, of course, Bill Sanborn and Jean-Fred Colombel and Paul Rutgerts did the clinical efficacy study looking at combination therapy in a population of patients with Crohn's disease who were immunosuppressive naive and biologic naive. And in combination, we see infliximab and azathioprine effective at inducing remissions at the end of 6 months in about 56, 57%. So we can see we've almost doubled the remission rate out of the controlled trials by going to earlier patient populations. And just as an example, this is the results of combination therapy in the ACCENT study on the left versus the SONIC study on the right, where we see a significant proportion of patients in remission in the earlier phase of the disease rather than waiting for late disease. And it's not just with infliximab. We can see that historically, looking back at clinical trial data with adalimumab from what's known as the CHARM study, where looking at the disease duration, the longer the duration of the disease, the smaller the absolute response rate. And it makes sense according to that graph that I showed you. And if we compare patients treated with adalimumab who were TNF naive, on the left we see significant benefits compared to the patients who received adalimumab as a second-line biologic therapy. So as Bill Sanborn last year, I played some rock music. In this case, the earlier is going to be the better. Now, the other aspect that I wanted to talk about, one of the other two, is the risks of our current positioning for anti-TNF agents. And that pertains to the infection, mortality, and neoplasia that Bruce showed some of the data that actually pertain to Crohn's disease, so I can go through that very quickly. The bad player in Crohn's disease, the biggest risk for serious infections and mortality, is not anti-TNF therapy, it's corticosteroid therapy. As far as the overall risk in cancer, and I'm just showing you one slide from the very recent Danish population of patients, in summary, is that when you look at the risk of neoplasia, and in particular lymphoma, in patients treated with anti-TNFs, after you adjust for the risk or the use of azathioprine, the risk pertaining to the anti-TNF disappears. The risk is with the concomitant medications, not with the ongoing biologic therapy. Now, what about the durability of response? I think this is really where we also have to focus in the future. This is one healthcare claims database that looked at the durability of patients initiated on infliximab therapy, and you can see within 1 year, only 50% of patients are persisting on treatment. After 2 years, it's less than a quarter of patients who are persisting on treatment. And Mark Osterman and the Penn Group have looked at another database. They were attempting to compare infliximab and adalimumab. They found no differences. But after 26 weeks, half a year of treatment, half of the patients were already off therapy. There are several problems to this. One is we're using it too late, and the other problem is we're not using them in the most effective strategies that we can. Bruce showed you some different mechanistic slides regarding vedolizumab, and vedolizumab has also been approved for the use in patients with Crohn's disease, not responding to conventional agents and or anti-TNF biologics. I'll just show you, since you've seen data with vedolizumab repeatedly last year and this year as well, I just want to compare one aspect, the late versus the early population. And if we just take the example, and Bruce showed you some slides in ulcerative colitis, but the same applies to Crohn's disease. First of all, the average duration of disease in patients in the Crohn studies was 10 to 12 years, depending on the 2 induction studies. If you look at the patients on the left who were prior exposed to anti-TNFs, having a longer duration of disease compared to patients who are anti-TNF naive, the naive patients did better in the clinical remission in the short term, as well as the durable clinical remissions over the long term. You can see that earlier patients get better outcomes, whether we're talking about anti-TNF or anti-integrin therapy. Now, one of the players that's in the background here, not the therapies, but how we use the therapies, is the role of therapeutic drug monitoring. And I'll emphasize that prospective studies are needed. Bruce did a wonderful job yesterday afternoon discussing the entirety of therapeutic drug monitoring with the thiopurines and the biologics, but we just want to talk briefly about these drugs having a pharmacokinetic pattern that, if we consider that there is a trough level, when patients go below the trough with in any of the biologics, and there's going to be data shown here that it also applies to vedolizumab, that serum levels reflect the benefits from mucosal healing to clinical response in both ulcerative colitis and in Crohn's disease from the SONIC study. But two bad things happen when trough levels drop. Number one, the response declines, and number two, the risk of immunogenicity increases. And we might recall that the anti-TNFs, infliximab, adalimumab, certolizumab pegol, and Crohn's disease, although we see this as the primary market, it's not the primary market for these drugs. The primary market is rheumatologic diseases and rheumatoid arthritis. And I would contend that all of these agents are being underdosed in our patients with Crohn's disease and in ulcerative colitis. As soon as patients lose drug levels, which are related to a number of factors that we've been discussing over the past several years here, the presence of immunogenicity or anti-drug levels, low serum albumin, high inflammatory burden as manifest by C-reactive protein, the kinetics increase and the clearance increases such that patients' blood levels drop and they lose response, they develop antibodies, and eventually they're off therapy. I'm not going to show you a slew of data, but leave it said that trough levels are associated with clinical remissions, lowering of the inflammatory burden as measured by C-reactive protein, and improved endoscopic outcomes. The problem is we don't have very good prospective studies. Most of the studies to this point have been retrospective analyses. And one that I would like to show you just goes back to the ACCENT-1 study, where we looked retrospectively at blood levels at the end of induction in patients, at the end of 14 weeks, to see whether or not those blood levels at the end of the induction phase would predict whether patients maintain their remission. And indeed, patients who had low blood levels at the end of 14 weeks were the ones who lost response and had to increase their dosing along the way. And we now know that in clinical practice, when that happens, the patients are developing antibodies and they eventually lose their response. So what are the real issues with our current positioning of biologics? Well, I've said for a number of years, if biologics cost dollars rather than thousands and thousands of dollars, we wouldn't be having these discussions. The cost of therapy is the overriding issue from all parties, including third-party payers. There's, of course, a fear of infection and neoplasia, but that's artificial. We've seen that these drugs are much safer than the most common predecessor to these, which are corticosteroid therapy, and the burden of side effects are related to steroids and immunosuppressives. The risk of lymphoma, as Bruce already mentioned, is quite rare, and in particular hepatosplenic T-cell lymphoma. From a patient's perspective, and often doctors, it's kind of a last ditch because they're afraid of running out of options and reserving for these refractory patients. So when should we be introducing biologics? If cost was irrelevant, we should be positioning them according to the need. And that would be when patients require steroids is where we should be inserting these therapies. We should be avoiding corticosteroids. The clinical trials have looked at late disease. The real potential is treating patients earlier in the course. So my question was, should we change how we position biologics for their use in Crohn's disease? And my answer is yes. The earlier the better in patients that need them with short-term combination therapy and therapeutic drug monitoring. And what will it take to induce that change? Longer-term pharmacoeconomic studies beyond the concept of hospitalizations and surgery into that of disease modification. It would be lovely to see trials in earlier populations before steroids, but our current companies have not been interested in engaging in this population, and I would also assert that prospective trials of therapeutic drug monitoring would be very helpful. Thank you.